right, good morning, everybody, and welcome to day 2 of our Psychosocial Professional Symposium, Psychosocial Oncology Professional Symposium, or POPS. You're joining us right now for the Impact on Us, Vicarious Trauma, Burnout, and Self-Care, presented by Sarah Field. My name's Kelly Hendershot. I'm the Vice President of Mission Delivery at the Cancer Support Community, and I'll be moderating today's session. Before I introduce Sarah, we do have a few housekeeping items. First, this session is being recorded and will be available for viewing after the event. You might want to give us until next week to make sure the recordings are fully up, but you will receive a follow-up email with links to the recordings. Continuing education credits can only be earned by attending the sessions live, not by watching the recordings. If you wish to receive continuing education credit from participating in this session, you will need to complete an online evaluation form, the link to which will be made available at the end of the symposium today, and it will also be available from that follow-up email. If you'd like to ask questions during the presentation, please use the Q&A feature in Zoom. We will try to hold questions till the end, but if there's a clarifying point, I will go ahead and interrupt Sarah to ask those specific questions. And if you would like closed captions on, there is a CC button on your Zoom toolbar. You might have to click on the little more circle with the 3 dots in it to have that visible. So now I'd like to introduce our presenter. Sarah is a licensed independent clinical social worker in DC, and she holds an oncology social work certification. Sarah earned her master's degree in social work at the Catholic University of America in DC and has worked in oncology for over 8 years. Since we're both in DC, I've had the privilege of meeting Sarah. And then Sarah currently is at MedStar Georgetown and previously worked at the Lombardi Cancer Center and GW Cancer Center. Sarah has a strong interest in the intersection of emotional and physical health and a particular passion for supporting parents with cancer and their kids. So please welcome Sarah.
Thank you so much, Kelly, and it's really nice to be here with all of you today. Look forward to talking about the way this work impacts us. So today we're going to be talking about vicarious trauma and related concepts. Before we do that, though, I want to also highlight, while not the purpose for this presentation, I want to recognize that the work we all do as social workers, therapists, nurses, other oncology professionals is oftentimes incredibly rewarding. We get joy, fulfillment, a new perspective from the work that we do. Now, today, though, we're going to be talking about some of the more negative impacts that the work can have on us. And by that, I'm talking about things like vicarious trauma and burnout and what we can do to take care of ourselves. And when I'm thinking about vicarious trauma and burnout, I'm thinking about it like an occupational hazard, just like you would protect yourself from needle sticks, from exposure to bodily fluids by wearing a mask. We need to be aware of what the risks of vicarious trauma are and what we can do to actively work to prevent them. The work we do is challenging. We are all exposed to the suffering of our patients and their families, and this in and of itself can cause us to suffer too. So today we'll be reviewing and defining concepts like vicarious trauma and burnout and compassion fatigue, and then we'll be talking about how can we address this? How can we address this professionally and personally to make sure that we're able to keep doing the work? And like Kelly said, if you have a clarification question, please by all means stop me so that we can be on the same page throughout, but otherwise I look forward to hearing your questions at the end. I don't have any disclosures to share with you all. So let's give a roadmap for today before we get started. The first is we'll talk about definitions to make sure we're starting out from the same place. I'll share with you symptoms and risk factors for vicarious trauma and the related concepts. We'll talk about how do we prevent this. And then we'll specifically focus on self-care. And I hope we'll be talking about self-care in a little bit of a newer way, since I know this is a topic that we often do hear about. So before we get started into the material and the definitions, I want to invite you to join me in just taking a couple of moments to ground yourself in the present, by doing this breathing practice with me, and I'll do it too as I lead you, but I'll invite you, if you want, you can close your eyes or just rest your gaze on a gentle place. Just inhaling and exhaling, softening your forehead, letting your jaw soften, and relaxing your shoulders. You might bring your shoulders up to your ears and then just slide them down, relaxing, allowing any tension that you feel in your body to release and melt away. You might notice what you're sitting on, whether it's a couch or a chair. Notice how it's holding you and supporting you. Notice that direct contact between your body and whatever you're sitting on. Notice your feet. How do they feel? How do your feet feel in your socks? How do your socks feel in your shoes? And how do your feet feel grounded to the earth, really rooting you to this moment? It might be the first time all day you've thought about your feet, so just notice that. Just taking a couple more breaths here. Inhaling and exhaling. When you're ready, you can gently open your eyes, maybe wiggle your fingers and toes as we go ahead. Thank you for joining me in that. I also want to invite you to join in some reflection, just thinking to yourself, reflecting on your motivations as a helper. What motivates you to engage in this work? Ask yourself, what drove you initially to engage in this work and to choose this path? When you were deciding what career to pursue, what was happening? What life events shaped your motivations to be in this caring role? The motivations and the life events that drew you to engage in this work define who you are, both as a person and as a professional caregiver. I'll share some quotes with you that really get at the heart of how this work impacts us. Dr. Rachel Remen is a physician who said, "The expectation that we can be immersed in the suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet." It's impossible, of course. And next, Dr. Charles Quigley is a psychologist who's credited with coining the term secondary traumatic stress, and he really expanded our understanding of this phenomenon. And what he was researching is that it's not just the individuals who are exposed to the trauma who experience traumatic stress, but the people, we who are providing care for them on a regular basis, who are exposed to these stories, also have very similar symptoms of post-traumatic stress disorder or PTSD. And so he expanded our knowledge of who's impacted by trauma beyond the victim or the patient to also extend to the people who are caring for them. So he said, "We have not been directly exposed to the trauma scene, but we hear the story told with such intensity, or we hear similar stories told so often, or we have the gift and the curse of extreme empathy, and we suffer. We feel the feelings of our clients, we experience their fears, we dream their dreams. Eventually, we lose a certain spark of optimism, humor, or hope. We tire. We aren't sick, but we aren't ourselves." And I think sometimes those of us who are in the helping profession, social workers, therapists, nurses, etc., we can be so caring and compassionate to other people, but we might not always attend to our own needs. And that's more what we'll talk about today. So I'll invite you to participate in some polls today. And the first one is, have you heard of secondary trauma or vicarious trauma before today's presentation? So I'll give you a moment to answer yes or no. All right, thank you. We'll end the poll and I'll share the results. many of you have heard about it, almost everybody. So excited to share this information with a couple of you who haven't. But again, I hope today we're talking about it in a little bit of a different way so that you can take away some learnings for yourself and also for the people you work with. All right. Let's talk about some definitions again, so we're all starting from the same place. Hearing about and witnessing and intervening in trauma influences all of us. On a daily basis, we're bearing witness to our patients and their families suffering. So some definitions to share. The first is countertransference, and you might remember that from your Psych 101 days, but as a refresher, that's our reaction to what the patient shares with us. And it's completely normal. We should not be afraid of countertransference. We should be aware of it. Secondary or vicarious trauma, you'll hear me use these words interchangeably today. That's the emotional, psychological, physical responses that medical and mental health providers might experience when they're exposed to the traumatic experiences of their patients. Compassion fatigue is a very related concept, and that's the emotional and physical exhaustion that can occur from prolonged exposure to the suffering of others. And that can really impact your thoughts, your mood, how you're feeling, your well-being, both at work and outside of work. And then lastly, burnout. So burnout's a state of chronic and physical and emotional exhaustion, and it's oftentimes accompanied by cynicism, detachment from your work, reduced job satisfaction, and it can also be accompanied by a sense of reduced personal accomplishment or effectiveness. You might feel powerless or helpless at work. Now, burnout itself is not specific to the healthcare environment, but the healthcare environment can be kind of the perfect breeding ground for burnout. It's a progressive state that occurs cumulatively over time, and it happens when your perceived support does not meet the perceived stress that you're experiencing. So think about high workload, high demands, high patient needs, high personal distress, and low support from your employer. And another important caveat related to burnout is while some of the symptoms and risk factors are very similar to vicarious trauma, it's not the traumatic material, it's not the exposure to patients and their suffering and stories that's causing burnout. It really is a lack of institutional support as well as high demand. So I'll ask you a second question here. In your experience, how often do you feel emotionally impacted by the experiences of your patients? Give folks just a couple more minutes to respond. Let me end the poll and share the results. If you see me looking over to the left or to the side, it's because I have a couple monitors here. But we have a wide range of responses here, kind of follows the bell curve in a nice way. So a few people said rarely, sometimes, and often get the most votes, and very often. So thank you so much for participating and sharing your experience. And I'll oftentimes tell people that, we're people first. Of course, we're professionals, but we're people first. And it makes sense to me that we are emotionally impacted. And again, just like countertransference, it's not something we have to necessarily shy away from or put up that brick wall to not be impacted, but it's more about having awareness of how the work is emotionally impacting us. I want to share with you now a vicarious trauma model, and this is actually from the Office of Victims of Crimes, but I think really nicely translates to the medical field. I included a QR code here in case you're interested in looking a little bit more into this. But this vicarious trauma toolkit introduces a new model for how we can understand vicarious trauma and the impact that vicarious trauma has when we are taking care of people who are experiencing trauma. So what this model says here is that if you're exposed to work-related trauma, then you're going to have vicarious trauma. And while individual people respond in different ways to vicarious trauma, one of the things that is inevitable that will happen to all of us is a change in worldview. So some people might become more cynical or fearful, sense that the world is unsafe, and other people will have more of a positive response, perhaps being appreciative for what you have, feeling grateful, a new sense of perspective, and you might have a combination of these responses. It might change over time, it might change individual to individual, and it might change with prolonged exposure. But again, that change in worldview is inevitable. Now, again, there's a spectrum of responses, and today, like I started out with, I told you we would primarily be focusing on that left-hand side in the negative column, where we're talking about things like vicarious traumatization, secondary traumatic stress, and compassion fatigue. And we're also going to talk about how we might have a neutral or a positive impact. So we may respond neutrally to workplace trauma exposure if the resources we have, the coping strategies we're using, the support that we have in place, resilience, experience, etc., allow us to effectively manage the traumatic material in a way that it really does have no impact on us. We're having more understanding now about some of the positive impacts. Like I said, the work we do can be incredibly rewarding. So on the right-hand side, you see vicarious resilience and vicarious transformation, and thinking about the positive ways we can be impacted by our work and specifically our work with people who are suffering. And so there, you might draw inspiration and even strengthen your own mental fortitude when you're witnessing a patient's resilience. And just as our patients can be, not necessarily, but can be positively transformed by illness or challenges, we too as providers, according to this model, can also experience this vicarious resilience and transformation. Excuse me. And compassion satisfaction reflects the sense of meaning that we get from working in healthcare. And it can motivate us, and it can also, importantly, help to offset the trauma. Excuse me. So let's talk about what this looks like. What are the warning signs? And just like with post-traumatic stress disorder, where you're going to see some overlap, these warning signs and symptoms can be behavioral, physical, and emotional. And I like to tell folks that it's not so important that you are accurately diagnosing yourself with, compassion fatigue, traumatic secondary trauma, or burnout, but more important, knowing what are your warning signs, how do these symptoms most often manifest in you, so that you know when to double down on your coping strategy. So let's talk about the emotional symptoms first. So somebody who's experiencing vicarious trauma might feel helpless or powerless. You might have apathy or impatience. You might feel your anxiety, fear, or irritability increasing. Mood swings and emotional exhaustion are common. And you might have intrusive thoughts or nightmares about your patient's experiences. It's feeling like you can't turn off your brain. There are physical symptoms. Some people have more psychosomatic symptoms than others, but if that's you, you might find yourself feeling fatigued, really tired, having sleep disturbances or difficulty sleeping, headaches or body aches, just not feeling well, maybe a decrease in energy too. You might have digestive issues or changes in your appetite where you may be eating much more or much less than usual. There are cognitive symptoms. Thinking might be challenging for you, difficulty concentrating, might be hard to make decisions both at work and outside of work. Feeling like you can't remember things, or like your brain is just cognitively overloaded. You might be worrying about your patients when you're not at work, or having hypervigilance, constant alertness, or an increased exaggerated startle response. And there can also be behavioral symptoms. So people who are suffering from vicarious trauma might withdraw from colleagues and friends. They might take more sick days than usual or take more breaks. They may report a reduced job satisfaction or burnout. Decreased empathy and compassion, both at work and outside. And substance abuse could be a coping strategy that really goes awry, and that's something to keep in mind. Another thing not listed here that I think is important to have a pulse on is a lot of people will report trouble with intimacy. So I want to invite you to participate in a third poll question. Which of the following emotional symptoms have you personally experienced in your work with cancer survivors? And please feel free to include all. Give folks just a couple more seconds. Thank you so much. Share these results. It looks like, over half of people report increased anxiety or fear, mood swings and emotional exhaustion gets almost 3/4. Intrusive thoughts or nightmares a little bit less common, but still prevalent. And I so wish we could know what other means for you, but of course we don't have that function within the polling. But again, it's important to, one, normalize that we are emotionally impacted by our work, and two, to just notice for yourself, what are the symptoms that can serve as your warning signs that you need to double down on coping strategies and attending to them, attending to the impacts. I'll share for myself, absolutely increased anxiety, mood swings, difficulty sleeping, just kind of waking up and thinking about my patients or thinking about them over the weekend in a way that takes away from what I want to do. Those are my warning signs. And just knowing for you how they show up can be really important to have that self-awareness. Let's talk a little bit more about risk factors. I hope by now I have convinced you, but not scared you, to know that all of us are at risk for vicarious trauma and the related concepts. And that's because we're working with people who are suffering. We are bearing witness on a daily basis to people who are experiencing physical and emotional pain. We're caring for our patients, we're caring for their families. But there are some things that put us at heightened risk. So, for example, prolonged exposure to traumatic events can put people at increased risk. Having a lack of emotional support or space to debrief. Social isolation, both at work and outside of work, as well as a tendency to avoid talking about your feelings or feeling your feelings, or a difficulty expressing your feelings, those can really put people at risk. That's why self-awareness and self-reflection is really critical here. If you yourself have a personal history of trauma or mental health issues, you may be at increased risk, especially if those issues have gone unaddressed. And having inadequate self-care practices is also a risk factor. Now, interestingly, even though prolonged exposure to traumatic events is a risk factor, it's folks who are early in their career, early nurses, early social workers, physicians, et cetera, who are at higher risk of secondary trauma or vicarious trauma, because they have less experience. They have less experience caring for themselves and managing this material. They also might have a increased or a lack of support. They might not have the same training and orientation, supervision in their jobs. And so it is really important, if you're working as part of a team that has newer people, newer providers, how can we step up and support them so that they are feeling as supported as they can as they start their career. So we've talked about what it is, what are the symptoms, what are the risk factors. Now, most importantly, what can we do about it? What are the antidotes to vicarious trauma? So we'll talk a little bit more about self-care, but let's talk about it briefly now. it's important that this is a continual practice of self-care. You don't just do these things when things are feeling hard. That's when you double down. But really, I can't emphasize enough the need for a continual practice. And so that might look like for you prioritizing regular exercise, healthy eating, getting enough sleep, taking good care of yourself physically. It also can mean engaging in activities that you enjoy, that are fun, that bring relaxation. And practicing mindfulness, meditation, and deep breathing. That's why we started this session out with that grounding exercise. That's an example of how you can practice self-care on a regular basis. Professional support's really important for prevention. So regular debriefing with colleagues or mental health professionals. I'll meet on a bi-weekly basis with a former mentor and colleague. We'll have lunch and we'll talk about how things are going. That's a great opportunity. On our ICU, especially during COVID, there was a lot of moral distress and trauma. And so one of our ethicists started a program where she rounds on a regular basis, but also on demand as needed, where there's just creates an opportunity for providers, physicians, nurses, medical assistants, techs, et cetera, to come together and talk about how are we doing, what can we talk about this hard case and how it's impacting us as a team and as an individual. That's really been helpful at our hospital. Seeking supervision and counseling to process your emotions. Boundaries is something we're also going to dive a little bit more into today, but touching on it really briefly here, how do we establish emotional boundaries that prevent ourselves from becoming overly involved? And how can we learn to say no when additional things are just going to overwhelm us? Education is really key. I am struck by how my nurse and physician colleagues oftentimes received almost no education on how the work we do impacts us personally. And so participating in sessions like this are so important. I feel lucky as a social worker that quite a lot of my graduate education was spent journaling and reflecting on how the work we do impacts us and recognizing countertransference, for example. But so many people did not have that in their program, or I've worked with medical students who have like one paragraph they write ever in their lives about how the work impacts them or what their reactions are. And so just normalizing the importance of training and understanding these concepts is really important, as well as normalizing when we need to seek help. And it's an opportunity for us, if you're working in the mental health space, to support our colleagues too, and to help educate them and gently guide them to seek resources. Workplace support is really important in prevention, creating a culture of open communication and support. Providing access to things like employee assistance programs or other wellness resources, and then to normalize their use. I work at a hospital system that really does encourage people to seek this kind of help. And it's great if you have the help available, but if nobody knows about it and nobody's encouraged to seek the help, then it doesn't go as far as it could. And then think about opportunities for rotating tasks so that you're able to reduce the constant exposure to trauma. If you work on a team, how can you share challenging tasks so that you're not the one person who's always doing them, for example? I want to share with you the helper's pit metaphor. It's something that really resonates with me, and I hope it's useful to you too. It's from Dale Larson. He wrote a book called The Helper's Journey, and it really gets at the crux of what we're talking about today. But in this particular helper's pit metaphor, he says, if you over-identify with the person in the pit, that's your patient, then you're going to fall in. And you're not going to be able to think objectively. You're not going to be able to act professionally or helpfully because you're going to be caught up in your own emotional reaction and your own distress to what the person's going through. And more importantly, the person in the pit, our patient, does not actually want us to be stuck in the pit with them. That is a really scary place to have your professional helper, because just think about it. As a professional helper, you're not going to be able to throw a rope or a ladder if you yourself are stuck in the distress with the person. And so by staying on higher ground, so to speak, maintaining that professional distance, not getting caught up in the person's distress that drives your own distress, is going to help protect ourselves, but it's also going to protect patients. I think sometimes people think, the nurse or the social worker or the provider who's like really in the trenches with the person is crying along with them, is really feeling their feelings, is, that's a strength. And everybody has their own practice style, but I would argue that to be able to do this work long term and to be most effective and helpful, we need to be able to stay on higher ground and have a little bit of distance. That's not to say you can't cry sometimes or to cry with your patient, but just sometimes I'll check myself. If I find myself becoming a little bit too involved, a little bit too reactive or responsive, I'll just ask myself, where am I? Am I in the pit? Do I need to get to higher ground? What do I need to do to get to a place where I can be professionally helpful and not caught up in the distress? This is a good opportunity to talk a little bit more about boundaries. So how can we create some work-life balance? Or I think the new way to talk about it is work-life integration. But how can we, as best as we can, leave work at work in this digital age? So I'll tell you a couple of things that I do and that I've heard other people do. One is I wear a badge, a lanyard around my neck at work. And at the end of the day, I take it off before I even leave my office. I put it in the same spot in my backpack, and I do not put it on again until I walk back into the hospital the next day. It just creates a little bit of distance. You're not going to see me at happy hour with my badge on. The other thing that I find helpful is as I'm walking into my home in the evening, as I put my hand on the doorknob, I'll just inhale and exhale once. It takes but a second. And it just allows me to leave whatever happened during the day outside the door as I walk into my home and assume my other roles that I have in my life. I worked with a therapist who gave an example where she would see, 8 to 10 therapy clients a day, and she found herself having a hard time leaving those therapy clients at work, so to speak. And so on her walk home, she would just purposefully, in her imagination, leave her patients, at the tree, at the stop sign, at the corner, knowing that they would be there in her imagination to pick up tomorrow or when she was going to see them next, but it just allowed her to sort of shed the day and leave her patients at work. Something else I find helpful in this digital age is on my phone, personal phone, but I have access to my work email. I moved my Outlook app to a different screen. I have to scroll and scroll and scroll because sometimes I would just automatically, my thumb would be checking my email before my brain had decided it was a good idea. And so it allows me just to pause and to take a breath and say, okay, I'm purposely checking work email outside of work because of XYZ reason, and I'm prepared, and it might increase my stress because God knows what's in my email, but it just allows me to be a little bit more purposeful rather than reactive. We heard yesterday from Dr. Reamer, for those of you who got to participate yesterday, all the ethical and digital reasons we should not be giving patients our cell phone numbers, but it's also a boundary thing, right? We shouldn't be receiving texts in the middle of the night or on a weekend or vacation from our patients if we're able to really practice good boundaries. And I encourage you to think for yourself, what are the boundaries that you have in place that are working for you, that you want to keep up? And where might there be an opportunity to shore up your boundaries or to make sure you're on the higher ground in this pit metaphor? So I invite you again to participate just in your own mind with some reflection. There's a formal assessment tool called the Professional Quality of Life Scale, and it has 30 questions, and it divides into 3 subscales where it gives you scores for compassion satisfaction, burnout, and secondary traumatic stress. And so that's a scale, the ProQual it's called, that can allow you to really objectively quantify how you're doing. But there's also an opportunity to just ask yourself in an informal assessment some of these questions, checking in with yourself again. How am I doing? What do I need? What's hardest about this work for me? What worries me most about my work? What are the things that are waking you up in the middle of the night, perhaps? What changes, if any, do you see in yourself that you feel uncomfortable with? What's my sense of personal accomplishment in my work? And what am I doing to take care of myself? Again, just picking a couple of these questions every once in a while, checking in with yourself to see how you're doing and what's hard, what are the pain points for you. So let's talk a little bit more about self-care here. And I like to say that if Instagram quotes and little memes and cute images, cartoons were the answer, we would all be experts at self-care right now. But of course, it's not the answer. And self-care is not massages, it's not manicures, it's not a competition, it's not about what appointment can I book, what can I buy, it's not something you can fail at. But rather, it's something that we need to be doing on a continual basis to take care of ourselves. And of course, going to get a massage or taking a long bath or going to a spa, those are all lovely. That sounds fantastic. And it's not something that we can do on a daily, weekly basis to make sure we are caring for ourselves. And so I like to think about doing micro self-care. And so that might be checking in with yourself mindfully, maybe asking a couple of those reflection questions I shared with you, taking an inhale and exhale, noticing your feet on the ground as you're going into a patient's room. Perhaps you're just, as you're sanitizing your hands, you're just noticing the way your hands feel together for just a second. It doesn't even slow you down. It's just about checking in with yourself mindfully in the moment you're already in. And also practicing awareness, noticing, when are you numbing? When are you dissociating? When are you pulling at your phone and automatically going on Instagram or TikTok or eating as a distraction to the uncomfortable feelings that might be coming up for you? And I want to highlight that it's not because we're weak. It's not because we can't do this work or we can't cut it. It's not you, right? It's the trauma that we are exposed to daily. And we need to actively work to offset the trauma. I'm struck that in a healthcare environment or in doing therapy with people, we are essentially in a one-sided relationship all day. We are caring for and caring for and caring for, and oftentimes people aren't really checking in on how we're doing. And so what we are feeling, what we are witnessing, really nobody knows. You know, even if you have that trusted person you can talk with, they still don't know the totality of your day and what you're feeling and seeing. And so how can we practice continual self-care in a way that allows us to release what we're experiencing during the day and at the end of the day? I'll ask you one last full question. How often do you engage in self-care practices to manage the potential effects of secondary trauma? Are we able to bring up that poll? Oh, awesome. Thanks so much. Give you just another moment. All right, thank you so much for participating. It's really nice to hear everybody's experiences. And so great to see that, again, we kind of have a bell curve, but lots of people are regularly engaging in self-care. Glad to see that. And I just encourage you to be curious about how you can do it more often. I would argue that it's something we need to do every day. Again, not a massage appointment every day, that would be crazy. But how can we just have micro moments, rest, hand on the doorknob, inhale, exhale, going for a walk, calling a friend? How can we think about those things that maybe you're already doing on a regular basis, but intentionally think of them as ways to engage in self-care so that you're managing and offsetting the effects of secondary trauma? So talking just a little bit more in detail about self-care. Self-care is a balance between awareness and practice. Now, by that I mean, so practice, that's the action that you're taking to care for yourself. That's the going for a walk, calling a friend, etc. But there's also a really important component here of awareness. What do I need to take care of myself today or right now? And it's also a balance between effort and release. I think we oftentimes think about the effort, the doing, the active engaging in self-care, the work that we're doing for ourselves and on ourselves, but there's also an important release component. And that's about practicing acceptance, and that's about allowing yourself some grace. And then practicing some self-empathy. I think those of us in a professional helping profession, we're really good at affording other people empathy, but how can we afford ourselves empathy? How can we be more patient with ourselves and compassionate towards ourselves? There's a yoga instructor named Elena Brower who offers the phrase, when you are feeling big emotions in reaction to somebody, for example, in reaction to a patient's experience or suffering, how human of me to feel this way? How human of me to feel this way when this happens? And just in recognizing your humanity and that it makes sense this is impacting you because you're not Teflon, that things just roll off, you're a human and you care, it just allows things to sort of soften a little bit and to that charge to fall away and hopefully help you feel better. How human of me to feel this way when this happens. In thinking about self-care, I like to think of it as a three-legged stool. So again, that's self-awareness. What do I need? What do I want? What is going to help me? Self-trust. Only you know what is going to help you, what feels right, what's true to you. I so wish that I could give you a 12-step plan and you would follow it and you would know what to do always related to self-care. But what works from person to person differs. What works one situation to different situation differs. And what was once effective for you might not be effective. And then how can you practice self-compassion? What in your life, in your work, can you give yourself some more grace and compassion about? And if you find yourself thinking, I should do more of this, or I shouldn't feel this way, those shoulds and shouldn'ts can serve as red flags. Then maybe you need to take some more time to think about how can you give yourself more grace? What is it that you need and what is true to you? So again, self-care can look really different person to person, situation to situation. It can change for me on a weekly basis. Sometimes it's saying no, and other times it's saying yes. It might be having a good cry, and it might be having a good laugh. Even amidst suffering, I think, especially some of my oncology social work friends have excellent senses of humor, and so having a good laugh is completely appropriate at the time. How can we allow ourselves more grace for a mistake? And there might be times where the answer to self-care is actually, how can we take accountability? How can we take steps to repair a situation? Sometimes it's stopping exercising, and other times it's starting exercising. Sometimes it might be being more gentle with your exercise. Sometimes being alone is self-care, and other times it might be surrounding yourself with people that you enjoy being around. I had a professor in graduate school who recommended have friends who are social workers who really get it, and have friends who have absolutely nothing to do with social work who don't get it. That way you can decide, who do I want to be around right now? Sometimes it's having a glass of wine after a hard day, and other times it's deciding that you're not going to have a beverage. It might be cutting out sugar and focusing on healthy eating. And self-care can also be letting yourself have the sugar and enjoying it. Sometimes self-care is setting goals and following through and accomplishing what you're hoping to accomplish, and other times it's doing the bare minimum. And all of that is okay. Self-care looks different depending on what you need and who you are. But no matter what's helpful to you, one of the most important things is developing a plan. I don't know about you, but when I'm my most distressed, most anxious, most overwhelmed is not when I come up with my best ideas for how I can take care of myself. And that's why it's really important to think about and be reflective and curious about what helps me. How can you create your own personal go-to list of things that help? And so this is just a couple of examples. This might not be what's on your list, but nature, a pause or a breath, calling a friend, prioritizing sleep, practicing more self-compassion. Those are all examples of things that could go on your personal list. And so I really encourage you today and in the coming days to think about what is on your go-to menu of things that help when you're needing to double down on taking care of yourself and your coping strategies. Also, one of the things I'll ask my patients when I meet them, when they're newly diagnosed with breast cancer, I'll say, what's helped you to cope with stress before all of this? And I get nervous. Of course, I get nervous when they say nothing. I've never engaged in any kind of coping strategies. I can't identify anything effective. But I also get pretty nervous when they only have one, because what if that one thing is exercise and there's going to be a period of time after surgery when they can't exercise in the way they used to? Or what if the only thing that's effective for me is calling my mom, and my mom is not always available to talk to? So how can we be a little bit creative? How can we expand our coping strategies so that we almost always have something that's available to us? So that's the presentation I have prepared for you. I'm excited to hear your questions and thoughts. Thank you so much.
Thank you, Sarah. This has been great. You've gotten lots of shout outs and compliments in the chat. I think this was perfect that we planned for your session to take place on World Mental Health Day as well. There is one question right now in the Q&A. So just a reminder to everybody attending, please use the Q&A feature if you have something that you still would like to ask. We're doing great on time. How can employees do a better job at attuning to employee needs and supporting them in their workspace to mitigate negative responses?
That's a really good question, and I think it's multifaceted. I don't know if that question is coming from a social worker, perhaps, because I'm struck by, as a social worker myself, I'm not just caring for the patient, I'm not just caring for the family, I'm oftentimes also caring for and educating and supporting my colleagues who are having emotional reactions, and then I'm caring for myself too. So it can be a little bit overwhelming, but I think education is key. Just sharing with someone today or tomorrow, oh, I attended a workshop, they talked about the way this work impacts us, and it's got me thinking how much suffering we witness on a daily basis, and gosh, it just makes sense that it impacts us. So normalizing the impact. And then also making sure you know what are the resources where you work so that you yourself don't have to take it all on. My colleagues will joke that they need to come see me for counseling, but they know that I'm not going to be their counselor. So, of course, I'll have lunch and we'll chat and support each other. And there's employee assistance programs. And so I'm the person that will sometimes say to my colleagues, there's employee assistance. It makes sense. This is impacting you. And our employer has the support available. Or there is wellness. Or did you know, on the 7th floor at lunchtime, they've got free yoga for staff, or a knitting program, or various things. So I hope that answers the question. Please let me know if there's more to the question that I'm missing. But I think normalizing and directing people to resources, educating them on these concepts is really important.
Great. It came in as an anonymous question. So if that person has any follow-up, just please enter another question in that tool or use the chat. One more did just come in regard to me as an LPC and my supervisor as an LSCW. I don't want to burden her. Something I tell my patients, they don't burden us. Question, how can we keep boundaries, but also use supervision to discuss vicarious trauma and burnout without fear of being talked about or losing our jobs?
That's a big question. I'll get to the first part first. I'll sometimes have patients who will say to me, I don't want to burden you. I don't want to bother you. Or they'll say, I don't want to burden my family or bother my family. And what I'll say to them, just a normal worry, we don't want to burden or bother our colleagues either. I'll say, sometimes I'll joke and I'll say, I'll let you know. If you're calling me too often, if you're bothering me, I will let you know. But until then, go keep it coming. Let me help. So that's kind of one way I joke about it a little bit with my patients and colleagues. But supervision is a space for you to share what you're experiencing and to get some support and normalize. And so I would encourage you to use that space, but also to express your worry. Gosh, it feels like I've been having such a hard time, and I don't want to burden you with my problems. Sometimes we or even our patients, they'll worry, like, I'm burdening my family. Well, has your family told you that? Because I bet the family members want to help. And I suspect, I hope, that your supervisor wants to help and wants to help you continue to do this work long term. So I think, it's a nuanced answer of hopefully you're probably not burdening them. Maybe that's your own sort of worry, and using it as an opportunity to talk about what you're worried about. Related to the job piece, I guess I'm not so sure about that. But I think doubling down on caring for yourself and reflecting, and just the fact that you are noticing the ways this work is impacting you can hopefully allow you to continue to do this work. I've been working in this field for about 10 years, and I haven't seen people lose their job specifically because they're being emotionally impacted, but that's where being aware of what your symptoms are. Like, if you're flying off the handle because you're so impacted and not able to offset the symptoms and to prevent them, then that may be an issue. Or if you are missing work because you're really struggling emotionally, well, then that would be an issue. But I haven't specifically seen that come up myself.
And related to that, somebody put in the chat that they wish that they had EAP resources offered at their employer. Do you have recommendations for those who might be attending who don't have access to an EAP program on how they can work with others to make sure that they're maintaining boundaries and getting their support needs?
Yeah, I think there's a handful of ways. One would be to work with your insurance to find access to your own therapy or support. You don't have to be in mental health crisis or have a diagnosis specifically to attend therapy. So, there's different online platforms that can make accessing therapy much more convenient and hopefully much more affordable. That's an option, seeking your own therapy. Also, just informal support. Like I said, I meet with a colleague for lunch. We call it a peer consultation. We have a nice time, but we also talk about difficult cases and what's impacting our work. That's another opportunity. And then I think advocating to see if there's ways to get the support within your place of employment. It might be there, you might just not know about it. So as we're entering open enrollment, really read on the fine lines related to all the different benefits you have access to. And then lastly, plug for things like if you're a social worker, or the Oncology Social Work Association, or the Association of Oncology Social Workers, I should say, or NASW, or various things where you can either go to conferences and network and support, or join different webinars. There's a meeting of people who are independent social workers. Well, what a great opportunity if you don't have other social workers around you to join with other social workers to support each other. So those are just a few examples off the top of my head. I hope that helps.
Great. And can you talk more about boundaries? The person who asked that said that they talk with other therapists, and that does help.
Yeah, I guess I'd be curious what the question about boundaries is, but we all have to sort of figure out like what boundaries work for us. And again, I'm not Teflon that things just roll off and I never give anything. Yesterday we talked a little bit, Dr. Reamer shared how he does personally self-disclose sometimes if it's judicious and appropriate. That can be like a little bit of a boundary issue, but just thinking about how do boundaries help you? For example, when I go on vacation, I sometimes decide not to check my email. And I sometimes decide I am going to check my email at the end of a week just to set myself up in a good place. I live in a really large apartment building, and I actually have a handful of patients who live in my apartment building, and I do not tell them that. And I just hope I don't see them because it's a boundary issue, right? I don't want them to know that their oncology social worker lives next door. They don't literally live next door, thank goodness, but it can create a boundary issue. some of us live in small towns where it's inevitable that, you know, the person on the PTA is going to be your patient. But I live in DC, it's just a huge city, and I still encounter patients, and it can be a boundary issue. So those are just a couple of things, but if you have specific questions about boundaries, I'd love to hear them.
Great. And unfortunately, there was no more detail. So if that person does want to add anything to the chat or to the Q&A for more specifics, please do so. We've got about 5 minutes before we need to wrap up. So we do have time for 1 or 2 more questions. While I am waiting to see if questions come in, though, I'm just going to go ahead and share some of my housekeeping closing remarks. Again, this was recorded, so all recordings will be available through our Zoom Events Hub and on our Facebook, or I'm sorry, on our website through February 10th, 2025. We hope to get some of those questions, or I'm sorry, we hope to get those videos posted possibly by next week. We do have some editing to do to them. But make sure that you are recording your CEs and submitting that form at the end of this conference. If you wish to receive that continuing education conference, the link to the form will be provided during the Q&A session, or I'm sorry, during the closing remarks session. And we've been sharing it throughout the conference as well. You can see it now in the chat. Just double checking to see if there have been more questions. I don't see any, so I'm going to go ahead and say thank you again, Sarah. This has been wonderful, and we will have our exhibit floor open again today. If anybody would like to spend some time connecting with LLS, Sanofi, and ASI, we want to thank them for also being sponsors today. And we will have some staff at our Helpline and My Lifeline booths later today. So thank you again, Sarah.
Thank you. Thank you all for participating.